A 55-year-old man is rushed into the emergency room, lights and sirens, major heart attack. Before he even arrives, the entire hospital mobilizes. The cath lab is activated. Within minutes, his blocked artery is opened. Door to balloon time, 40 minutes, outstanding care. The next day, everyone is congratulated. Emails go out praising how fast we acted. But as I drove home, I had a different thought. Are we rewarding the wrong behavior? This patient had done everything right. He took his medications exactly as prescribed, including Plavix, the blood thinner he'd been on for 5 years. Here's what no one told him. For 1 in 3 people and 1 in 2 people of Asian descent, Plavix doesn't work well. The reason? Genetics. Plavix is what we call a prodrug. It enters your body inactive, like a blank key. Your liver has to cut that key using an enzyme called CYP2C19. But 30% of Europeans and over 50% of Asians carry genetic variants that impair this enzyme. Their bodies can't activate the medication effectively. The result? A blood thinner that doesn't adequately thin the blood. The clinical consequences are significant. Nearly 3 times the risk of stent thrombosis, 57% higher risk of heart attack, stroke, or death, 67% higher risk in the critical first year after a stent. That patient, 5 years on what was essentially a sugar pill for his genetics. This harm is entirely preventable. With a simple genetic test, results available in about 1 hour, with point-of-care testing, we can determine how your body processes Plavix. The test is covered by Medicare and most insurance for patients with acute coronary syndrome or stent procedures. A simple cheek swab or blood sample. Results before you leave the hospital. Based on your results, we personalize your treatment. If you're a poor or intermediate metabolizer, we switch you to alternatives, prasugrel or ticagrelor, that work regardless of your genetics. The evidence shows this reduces complications by 30%. If you're a normal metabolizer, Plavix works well for you. You may have 22% lower bleeding risk compared to more potent alternatives, and you'll save money with generic Plavix at about $10 per month. This is precision medicine in action, not one size fits all, not guesswork, the right medication for your biology. Genotype-guided therapy optimizes both efficacy, preventing clots, and safety, minimizing bleeding. So why isn't everyone getting this test? It's not the science. The FDA issued a boxed warning in 2010. Clinical guidelines strongly recommend it. Major medical centers, Vanderbilt, Mayo Clinic, Cleveland Clinic, routinely implement it. But in general practice, fewer than 10% of US cardiologists test for it. The barrier isn't evidence, it's implementation. And that's where you come in. You can ask for this test. Questions to ask your cardiologist. Do you routinely perform CYP2C19 genetic testing? Can we test in my case? How will my results change my treatment plan? Your genetics don't change. This is information you'll have for life. One test, 1 hour, better outcomes. Because the goal of medicine isn't just to react quickly in an emergency. The real goal is to prevent the emergency from ever happening.